And it is our honor to introduce today's speaker, Dr. Mauricio Tohen. Dr. Tohen is the University Distinguished Professor and the Chairman of the Department of Psychiatry and Behavioral Science at the University of New Mexico in Albuquerque. And we encourage you to read his full bio at ibpf.org. So thank you for joining us today, Dr. Tohen.
Thanks much for the invitation, International Bipolar Foundation, and thank you all of you who are here for this presentation. I am aware that some of you have lived with the condition, or you have a loved one who has lived with the condition, or a caregiver, or you take care of individuals who suffer from the condition. So I will, keeping that audience in mind, at some point, I will review things that are maybe basic, but then we can expand. And as mentioned, at the end, we are ready for questions. So we'll do a presentation. It'll take anything from 35 to 45 minutes. So let's start with a disclaimer. I started I was born in Mexico City, and then I came to the US, as many people do, for education. I was first in Toronto, and then I was 15 years in the Boston area. And then I actually worked for the industry doing clinical trials. Now, as mentioned, I'm in New Mexico, beautiful place. If you've never visited, I encourage you to visit New Mexico. And I look after the department. So I look after the faculty, residents, but very important, I continue to do clinical work, do research, see patients. The majority of the patients who I see are individuals with bipolar disorder. I see them in the outpatient clinic. And we have a psychiatric emergency center. Actually, we have a new one. So I frequently see individuals who are suffering from the condition, are in acute phase of the condition, perhaps because the medication was stopped. Unfortunately, medication doesn't always work. And also there's comorbid conditions. So many individuals who live with a condition of bipolar disorder, it's not unusual to have comorbid conditions. One of them is, of course, substance use disorders. So let's talk a little bit about bipolar disorder in terms of its treatment. So what you see in the graph, this is where this is the treatment. This is a population who has been hospitalized, and this, what you see in days, is when either treatment is stopped or the treatment that was started in the acute phase was switched to something else. So as you can see, the initial treatment frequently changes. By week 12, less than 50% of the patients were taking the same medication. And then, unfortunately, what also happens is that the medication is stopped. And many reasons. Number one, medication. I'm going to focus my presentation on medication without ignoring psychosocial therapies. But my area of expertise is medication. So we don't have a cure for bipolar disorder. Many times my patients will ask me, "Doc, when will I stop my medication?" And my honest answer is, my recommendation is not until we find a cure, and we don't have that cure just yet. There is a low percent, less than 10% of individuals who suffered just one episode only. But the majority, unfortunately, is more than one episode. So the treatments, again, do not cure, and they have side effects. So it's not surprising that the medications are stopped. And also they're stopped because they work. So let's say you have active symptoms of mania. The mania goes down and you're doing well, but then you're having the side effects. So of course the thinking is, I'm doing fine. but I'm gaining weight, or I have tremor, side effects. Why should I take the medication? So then the medication is stopped. So reasons why medications are stopped, and this is again, and this was a European study that we did many, many years ago. Lack of efficacy. Yeah, there, and unfortunately, we're not at the level of precision medicine, like in, for that matter, cancer or an infectious disease, where you can get a culture or you can do a gene analysis and you know what is the medication that you need. We're not there yet in psychiatry. I think we will in our lifetime, but we're just not there yet. So lack of efficacy, that's the most frequent. And this, it might be switching to another medication. Not tolerating the medication. And then, of course, as mentioned many times, patients will say, I really don't want to take the medication. And at the end, it's the patient's decision. So myself, when I'm talking to one of my patients and doesn't want to take the medication, patient is doing well, I will advise not to, but I know that at the end, it is their decision to stop the medication or not. And of course, I express concerns, but I will let them know if symptoms do resurface, I am there. Lack of compliance, and that is, of course, it's not that you take it or not. It's not, it's more in the gray area. Might you take it one day, but then forget for 2 days, or choose not to for whatever reason. Taking more than one medication is not uncommon. So maybe instead of taking 3 or 4, that day you decide to take just 1 or 2. So there's different reasons why switching treatment is frequent. I can tell you that the number one reason why patients stop or why patients relapse, it's non-adherence to treatment. And it could be an now, of course, the medications that we use in this treatment of mania, they're called antipsychotics, but they're mood stabilizers as well. But a generic term would be antipsychotics. Of course, lithium is not an antipsychotic, but let's use the term antipsychotic here. So non-adherence is actually quite high. And let's say that the medication that has worked is an antipsychotic. And this, I'm focusing on mania rather than on depression for the moment. So 40 to 60%, there's non-adherence. So of course, the risk of relapse is high. And there's also, as I've mentioned, mild or poor adherence to treatment. And this actually happens, as I mentioned before, when you're well, when so-called euthymia, because you are not having any symptoms, but you're having the side effects. And then because of side effects, and other reasons for stopping medication could include comorbidity. Unfortunately, when there's a bipolar disorder, especially of many years, the majority of individuals suffer from comorbid conditions, anxiety, substance use disorder, and medical conditions. So that is also one of the reasons why patients stop their medication. Lack of social support, that is another one. Let's look at the course of illness. The more the number of episodes, the more likely to have a relapse. So what you see in this curve, this is, here everybody's fine, okay? And this is after hospitalization. And this is time to relapse. So individuals who've just been hospitalized once, within, and this is in years, about half of them will have a relapse within 5 years. But for patients who've had 4 episodes, then the time of staying in remission, the risk of staying in remission is much lower. And this is similar in terms of men and women. In other words, a good predictor of the future is the past, meaning if there's been many episodes in the past, the likelihood of having a relapse sooner rather than later is larger as opposed to individuals who've had 1 or 2 episodes only. The take-home message here is that having a relapse is not only the risk of self-harm or harming others, in addition, or losing employment or breaking up of relationships and so on. There's the relapse in itself has those risks. But in addition to that, and this is what this is the message for this slide, is the more the number of episodes, the higher the risk of continuing to have more. So that's why it is very important to try to prevent episodes. There's in the past, we used to use the term kindling, that again, each episode increases the risk of future episodes. Just to keep that in mind in terms of the importance of staying well and adherence to treatment when treatment works. This is what we see in mood stabilizers. One of the good things about the mood stabilizers like lithium or valproate is that you can get a blood level and you will determine what is the right dose. So and this is again adherence. In other words, if you're taking something like lithium and only take it a few days, or you stop it, or not taking the right dose. So this, of course, if you stay here, that means you stay in remission. So when there's adherence to treatment with therapeutic levels, as you can see, the chances of staying well is the highest. Then you see patients who take the medication, but for one reason or the other, the levels are subtherapeutic. It could be not taking the medication, or it could be that for whatever reason, the prescriber is suggested a lower dose. So even if the medication is stopped, but if it's not at the therapeutic level, higher chance of relapse. Now, when there's partial adherence, one day yes, the other day not, that increases the risk. But as you can see, and not surprisingly, of course, the highest risk, like you see here, within 2 years, patients who take the mood stabilizer at subtherapeutic doses and partially adherent, again, you can see the risk of relapse is very high. So how can we improve adherence? And let me repeat it. I'm going to focus on medication, not ignoring psychosocial treatment, support, what have you. Exercise. We know how good is exercise. Like I run every day. It keeps me well. So let's not ignore the good habits, but let's focus on medication. So an option to make sure that the patient takes the medication and at the right dose is the long-acting antipsychotic medications. That is, for those of you not familiar, it is a medication that it's an antipsychotic. It's used in schizophrenia, but as mentioned before, antipsychotics are also very good treatments to treat the acute mania and to also to maintain adherence. So it is key when you use a long-acting antipsychotic, the injection is given once a month, every other month, every 3 months, or every 6 months. So what are the advantages? Number one, if the patient comes and gets his injection, and then let's say it's a monthly injection, and you see the patient a month later, obviously then the patient is adherent to the treatment because he's getting the injection right there. So it's very good for monitoring treatment. This is actually for those folks who live with someone who has a condition, just to know that the loved one is taking the medication, of course, helps the caregivers. And of course, it could be the spouse who's concerned about, or the mother, or the son, what have you. So that it's also helpful for the system. Also, the other thing is that if, like for instance, I have patients on long-acting intramuscular, And I usually see the patient the day they get the shot, and after they get the shot. And then if my patient doesn't show up, I would usually call them, and then hopefully then we will reschedule both the visit and taking of the medication. Now, I did also mention that medication can be given every 6 months. That doesn't mean that I will see the patient every 6 months. If the patient needs to be seen monthly, I'll see the patient monthly. So not really connecting my visit as a psychiatrist to the day they got the injection. But you can do that. Actually, many times when I see someone who just had a manic episode and is well, I'll see the patient the next week or 2 weeks just because that's a risky period, even if they got the injection. So again, it helps with monitoring, but do not marry the day of the visit with getting the injection, because then the 6 months would be that you won't see the patient there's some patients who I see every 6 months or once a year, but it really depends. It really depends on the patient's needs and so on. So let's review the studies that have been done with long-acting intramuscular. So the medications that we have here, as you can see, these are the different medications. These are the different publications. And as you can see, the publications go back to actually the last century, in the 1980s. So there's a number of studies that have been done, and we'll review them with more detail in a moment. Let's talk about the long-acting in bipolar disorders. Well, first you have to make the diagnosis, and sometimes making the diagnosis of bipolar disorders can take years. Sometimes patients are misdiagnosed. So the long-actings, of course, can improve the adherence to treatment and prevent the relapses. So the ones that are available, here's that list. Actually, flufenacin is available in Europe, not in the US. It was the first long-acting antipsychotic. It was in the 1960s, so it's been around. And these are the first generation antipsychotics. The other one is haloperidol, and of course, it's available in the US. Haloperidol is an effective treatment for acute mania or psychosis. It is not the ideal treatment for maintenance, because studies have shown that haloperidol can actually cause depression. So that's obviously something you want to avoid. Then you have risperidone, is the first second generation, and paliperidone, who they develop a long-acting antipsychotic. And they're effective in preventing manias, but not in preventing depression. So it's not, so unfortunately, the use of long-acting antipsychotics, they're better when the relapses are to mania, but if the relapses are to depression, it is not the ideal treatment. And of course, you have relapse to both poles, so then the long-acting antipsychotic itself would not be enough. Olanzapine, it has its pros and it has its cons. It is available in long-acting. However, the olanzapine long-acting intramuscular, the patient has to be watched for 3 hours because it can cause severe sedation. So it's inconvenient for the patient. And also, of course, olanzapine is effective in treating like acute mania, but unfortunately, it causes weight gain, increase of triglycerides, and contributes, of course, to diabetes. So it can prevent manias and depression, but it has its problems, which is tolerability. And of course, this is a medication that you're gonna use for a long time. And unfortunately, the weight gain with olanzapine doesn't stop. it plateaus, it kind of slows down. So you have the curve here, and then it doesn't really plateau, it continues. Aripiprazole doesn't have the risk of the weight gain, but same as risperidone and paliperidone, does not prevent the depressions. So we do not have an ideal long-acting antipsychotic. So we shouldn't think of it as the solution, but it's something that we can use. Again, it helps with adherence. In general is good in preventing manias, not 100%, but they're not good in preventing depression. The only one, olanzapine, but we also talk about its problems. So we just have to think that this is part of our treatment. We can't, unfortunately, we can't say this is the solution and only this. It has to be in combination with other treatments. We've mentioned the typicals. Here you have the studies. As you can see, they go back to the 1980s. But as mentioned, they have the problems that I just share with you. We can make this slide available. Now, this is an interesting study that looked at, of course, we want to prevent hospitalizations for many reasons. Number one is that if there's a need for hospitalization, that means there's an acute episode where the patient is at risk of hurting himself or others, or most frequently being victimized. When someone is psychotic, that person is very vulnerable. So and this study was interesting in that it decreased the number of hospitalizations. And this is time to hospitalization after the medication was started. And this is with the different antipsychotics. So as you can see, they prevent hospitalizations, but not 100%. This is if it crosses this line, that means it works, okay? So flufenacine, 1 year to 5 years, there were some patients who relapsed. Haloperidol appeared to be better, and risperidone, but as mentioned before, the risk of haloperidol is causing depression. And here you have the same study. This is for longer duration. The one that appeared to be better was haloperidol and risperidone. So this was a review. It's not head-to-head studies. This is what's called a meta-analysis, where you look different medications and you look at the differences. Now this is another review that is also very, very similar. We won't look at it in detail, but this is indicators of why when patients with antipsychotics are helpful. So these are the indications. So with it helps in preventing manias. So severe manias, that would be clearly a patient who would benefit from long-acting antipsychotics. Patients who relapse because they discontinue treatment. And this is the other point that I've mentioned before, but I would like to emphasize. They're most effective when the type of episodes are predominantly manic, not depressed. And then, of course, as mentioned, they can be part of our armamentarium, where they can, you give the long-acting antipsychotic, but you also give other medications. Schizoaffective bipolar, of course, is another use. Now the FDA, approval by the FDA is very important, not only for efficacy. I mean, not only for efficacy, for safety. If a drug is not approved by the FDA, there's no data that it is safe. And of course, many times we prescribe drugs that are not approved for that indication. But then, of course, the patient should know the FDA has not really approved this medication for this indication, and there's no clear efficacy or safety data. The only atypicals approved by the FDA, long-acting, are risperidone and aripiprazole. I've mentioned olanzapine, but it's not approved for bipolar disorder, only for schizophrenia. So these are the only two approved in the US. Let's look at the data with aripiprazole. And this is the study was for 1 year, and if you can see the difference, these are patients. This is a 1 year, 52 weeks. So these are the placebo patients. So as it goes down, that means there's more relapses. And this is with aripiprazole. So here that means it's significant, as you can see. So clearly better than placebo, but not perfect. In other words, yeah, there was 20% of patients relapse within a year. With placebo, it was 40%. So not perfect. It didn't keep everybody well, but definitely better than placebo. Now this is the number of patients. So this has to do with the proportion of patients to any episode. So this is mania or depression. So as you can see, aripiprazole is quite effective in mania, but this is of course the problem. It is not better than placebo in preventing depression. It does prevent mixed episodes. So data, I would say, strong in preventing manias, but no different than placebo in preventing depressions. I mentioned haloperidol. Haloperidol would actually be worse than placebo. There's no head-to-head studies, but just looking at the data, it's depressogenic, which you could argue at least with let's say a patient who benefits from aripiprazole for preventing mania, but also has depressions. So you need to think of something else. And I'm not going to say what is the best treatment. The best treatment depends on the patient. So whatever is the best treatment for that patient. For instance, the use of antidepressants, they're contraindicating monotherapy in bipolar depression. In bipolar disorder, but in combination with an antipsychotic, that could be used. So it could be preventing in bipolar disorders. Some patients could be with antidepressants. There's other mood stabilizers, like for instance, lamotrigine. So it's not I'm recommending something specific. What I'm trying to illustrate or emphasize is that there's options. And the best option is whatever is best for the patient I have in front of me. So this is the same study, and this is looking at mania. So as you can see, this is when the patient was stabilized with the oral medication. This is still the aripiprazole study. And as you can see, the score of the YMARS is the score for mania. It goes down. Down, of course, is good because that's severity. And then when it's placebo, obviously it goes up. These are patients who are randomized here, but when it comes, those on aripiprazole, they stayed stable. Okay, so placebo ones there was worsening. And then this is time to discontinuation. This is placebo, and these are those with aripiprazole. Again, there were still some who relapsed, but more so if they were taking placebo, if they received placebo. Now this is now the question is, what about my ability to function? Because what really matters to patients is not just do I relapse or not, but can I function? And this is a scale that looks at functioning. And as you can see, it is better than, if it goes up, that is not good. So placebo in terms of autonomy was worsened. As you can see, the occupational functioning, really there was actually worsening with the group of those aripiprazole. Cognition, they did better on the medication. So this measures different. None of these are statistically significant. The only one that was statistically significant is an important one, which is interpersonal relationships. This was the same study that I've been talking about, which was not really focusing on functioning, but still you can do functioning. This is the most common side effects. Again, there's no drug free of side effects, unfortunately. So weight gain, as you can see with placebo, 18%, with akathisia, weight gain, not as much as with olanzapine, but there is weight gain. Akathisia, restlessness, you do see that would be the most common side effect that you can see. And then there's not much difference between placebo and aripiprazole. Now, mania, it's of course not a side effect, but as you can see, you have more manias with placebo than with aripiprazole. So again, the main risk, this is the one that was statistically significant, was akathisia, which is of course restlessness. Weight change, really not significant. You did see some patients. This is the number of the 128. There were 23 that gained weight. Not much difference than with placebo, 18% versus 12%. And actually weight loss, as you can see, there was actually more with placebo, but also some with aripiprazole. This is the BMI, and as you can see, this is with aripiprazole and placebo. You do see an increase with those with aripiprazole, and especially in those who had low BMI. So this is important. The risk of weight gain is higher for those who are underweight as opposed to those who are overweight with any medication. That's important, something to keep in mind. Like you can see here, the patients who had a high BMI, to be if it's over than 30, that is overweight. And as you can see, there was really no difference. Akathisia again was the main side effect of aripiprazole. And as you can see, this is following monthly by month. This study that was continued for over a year, and this is the maintenance. These were patients who were all on the long-acting aripiprazole, and as you can see, the rollover means those who were taken in the double blind, and then those patients who were giving the antipsychotic without going into the double blind. So as you can see, there's more side effects in the new ones than in the rollover. Patient satisfaction, it was, you can see there were 40%, good number, not the majority, who were extremely satisfied, and unsatisfied is, of course, lower. Now, this is, of course, a population who agreed to be in a study. So you would expect that those, if there was, that didn't matter in terms of expecting being satisfied or not. So this is the stable. Let's review the data for risperidone, which is the other one that was similar design. So here's the result. These are the patients on placebo. These are the patients on risperidone. So as you can see, there is a difference. This is relapse to any type. Now you can see this is looking at mania, placebo relapses, risperidone much less. But unfortunately, no difference in terms of prevention of depression. This is placebo. This is risperidone. So it didn't cause more depressions than placebo. It's not depressogenic, but as you can see, it didn't help. So basically, the same story that we saw for aripiprazole. So similar results we see here. Now let's look at treatments recommended by CANMAT. CANMAT is an association that started in Canada and now is part of ISBD. And these are the different treatments. Of course, lithium is a medication that sometimes we don't think about a lot. It's a medication that when it works, it really works very well. Unfortunately, it doesn't always work, but I always like to say every patient has the right to see if they respond to lithium. As you can see, it's really trial and error. You can't predict who's going to respond. So it is a medication, and this is for maintenance that we always need to consider. So let's not forget about lithium. Then what we have in this list is also medications that don't have long-acting intramuscular. Quetiapine is another one that it's the CANMAT recommended, not available in LAIs. Lamotrigine, I mentioned it. Lamotrigine prevents depressions, but does not prevent mania to a higher degree than placebo. So as you can see, the opposite of what we saw with aripiprazole or risperidone. And then other treatments that would be the second-line treatment, olanzapine, of course, we saw, and this is for maintenance of problems with weight gain, and then you see other treatments. This is in terms of tolerability of the different medications. Weight gain, of course, the highest is olanzapine, clozapine, and quetiapine. Less so with aripiprazole or some of the newer antipsychotics like lurasidone, less weight gain. So to summarize, let's not forget about long-acting intramuscular antipsychotic medications for bipolar disorder. If you ask my colleagues, do you think patients will like it? The answer is no. I think they hate injections. But when studies have been done asking patients, the answer is very different. It's not that everybody would say, yeah, nobody would love an injections, but they would say it would help me, I would take it. So there's more concern on the part of the prescribers than patients themselves. So this is the decision, of course, has to be made by the patient and what they want to take. But our obligation as prescribers is to let patients know what options are available, and then we can make recommendations, talk about side effects, but it is a collaborative approach. So as mentioned before, the only available antipsychotic long-acting are risperidone and aripiprazole, and as I've mentioned many times, effective against preventing mania, but not in terms of preventing depression. So with that, we stop. I'm going to stop sharing my screen. It's a tool that we have for bipolar disorder that I think it's underutilized. And as I mentioned many times, to consider, it would be few cases that I would consider using it alone for the reasons that I've already mentioned, but it's an option that we have. So thank you again for joining us, and I'm open for questions or comments or different points of view. Please.
Dr. Tohen, thank you so much. And as it was just said, we're going to move forward into our question and answer portion of today's talk. And our first question is, do you need to take a mood stabilizer alongside LAI antipsychotics for bipolar?
Yeah, so just the way the question is phrased, do you need? The answer is no, you do not need every time. Can you use? The answer is yes, you can. So I wouldn't say that in every time you have a long-acting antipsychotic, you need to add another medication. But I would say in the majority of the time, you would need something else. The only time where it could be used alone would be in a patient who has predominant episodes of mania. There's actually a definition of predominance mania, predominance of depression, and that's when more than 60% of the episodes are of one type or the other. But even if there's a few and you're concerned about depression, so yes, in the majority of cases we do, but not the one, as I mentioned before, patient who just has manias, that might be the only time that I would think about the LAI alone. Thanks for the question.
So our next question is, how is the frequency of the injectables determined?
That's a very good question. Well, number one is first answer is an obvious one. Well, you need to know if there's for that specific treatment, if you have 1 month, 2 months, 3 months, 6 months, etc., and does it have the label from the FDA? Has that been approved by the FDA? So, as I mentioned, the FDA has only approved risperidone and aripiprazole for bipolar disorder. For risperidone, it has approved the monthly. For aripiprazole, there's an approval for every 2 months. Now, there is a risperidone that's every 3 months and every 6 months, but the FDA has only approved it in schizophrenia. And approving it doesn't mean that it disapproved it, that a study was negative. It means that it hasn't been studied. But this is, if a patient wants to be on the medication every 6 months, again, risperidone is available, but I would make sure that the patient knows that it has only been approved for schizophrenia. The physician can prescribe it for bipolar, but the patient needs to know that. And the main reason is that when we have, it's not been approved by the FDA, we don't have safety data. So the answer is how often? That's patient's preference. Actually, I have patients who prefer the monthly for whatever reason, others who prefer every 2 months. The advantage of the longer, let's say 2, 3, or 6, is that the risk of relapse is actually lower because you can also have non-adherence to an injection. So if you take the monthly and then you don't take it that month, as opposed to if you take the 6 month, then you will be covered for 6 months. There's another important point about the long-acting intramuscular, that the blood levels are stable. Okay, so it might be sometimes if you take the medication at different times of the day, your blood levels are not going to be stable. So it gives you have evidence of adherence, but also evidence that there's stable doses. So again, how often really depends on the patient's choice.
Thank you. So our next question reads, our audience member wants to thank you for the presentation, and it reads, is there any experience with using zuclompentixol and flupentixol deconates, and they sometimes have mainly the typical antipsychotics in the African setting?
Well, flupentixol is a first generation antipsychotic, and it causes depression. So it's actually, actually there's been studies that have shown that patients who are taking flupentixol injectable have higher risk of depression than those who are taking something else. Specifically in terms of available in, I think it was in African countries, I don't know. It is available in Europe. I just don't know if it's available in the African continent.
And so our next question reads, is IM paliperidone approved for bipolar mood disorder?
Yes. Oh, no. The one that is approved is risperidone. Paliperidone is approved in schizophrenia, but not in bipolar disorder.
Thank
now,
you.
Do some folks use it? It is used, but it doesn't have the approval. Now, there's another problem with not having the FDA indication. And it is that if it doesn't have the FDA approval, it will not, in many cases, it will not be paid by the insurance company. Sometimes there's sort of an appeal. And if you can demonstrate that that particular medication, even if it's not approved by the FDA, it has been helpful, it has to be approved by the insurance company, and sometimes they don't. So that is also a problem. Not approved, it won't be paid by the insurance company. And they're very expensive medications, I must say. It's in the monthly medication would be $2,000. So very, very few people will be able to afford that. So that's something. Actually, one of the things that when I'm with the residents and I ask them, well, what medication are you going to choose? And then they'll say, well, a medication X. And I will say, do you know the cost? And sometimes they don't know. And New Mexico, it's a poor state, so cost matters. And knowing the cost of the medication, because not being able to afford that medication by a particular patient is a very frequent reason for non-adherence. So we as prescribers should be aware of the cost.
And then, so our next question is there any research on taking ORAP or Pimozide tablets as an antipsychotic for schizoaffective bipolar 1?
Pimozide it's a medication not widely used in the US. It's an old medication. It was actually, there were some studies that show that it was good for psychosis with tactile hallucinations, feeling bugs and things like that. The problem with Pimozide is that it increases the QTC, and QTC is part of the electrocardiogram, so it has cardiovascular risks. There are no studies. It's rarely used, and of course, one of the reasons it's its safety. And many of our drugs increase the QTC, so then you want to avoid those drugs. It's rarely used, and it's not well studied in bipolar, and it certainly does not have the formulation of a long-acting.
Thank you. So our next question is there any research on switching to aripiprazole from Invega Sustenna to combat side effects of weight gain?
That's a great question. It doesn't come to mind. That doesn't mean that there is. I would say that that's a very reasonable question. If I have a patient who has been taking risperidone or paliperidone, they cause more risk, more weight gain than aripiprazole. I think it's a reasonable change to make. I am not aware of any studies that have shown that, but I would expect that it would show weight. So whoever asked this question should bring it up to the prescriber. I think it's a reasonable question.
Thank you. So our next question is there an injectable mood stabilizer for maintenance in bipolar 1?
The answer is unfortunately not, but it also is how you define a mood stabilizer. So traditionally, only lithium and some of the anticonvulsants have been called mood stabilizers, but actually there's antipsychotics that do stabilize mood. But the ones that are typically known as mood stabilizers, again, lithium and valproate, they're no long-acting intramuscular. I know there's some research going on with new compounds, and what's being considered is the availability of a long-acting intramuscular.
Our next question is, do you have any thoughts on the continuation of mood stabilizers in the case of continuous manic episodes?
If a patient has had frequent relapses, clearly one should continue the mood stabilizer. So yeah, studies have shown that if a patient is being stable on a mood stabilizer and the medication is stopped, then you increase the risk. Something about lithium, as I mentioned, it's a medication that we should not forget. But one of there's side effects, as all medications. But another thing that we've seen is that when lithium is stopped abruptly, the risk of relapse is very high. So, for instance, when I have a patient who's taken lithium and for every reason we wanted to switch it to something else, we have to discontinue lithium very slowly in a matter of 2 to 6 weeks. What you don't do is just stop abruptly. So many times one should worry about the use of lithium in patients who are non-adherent, because if they stop the lithium abruptly, the risk of relapse is actually higher than being on no medication. So that's a warning.
So our next question is, are there any new developments in LAIs that focus more on targeting depression?
No, unfortunately, that I'm aware of. So again, LAIs are long-acting antipsychotic intramuscular. The quetiapine, for instance, which is a medication that does prevent depression, it causes weight gain and sedation. To my knowledge, there's no studies as an LAI. Olanzapine, as I mentioned, has the indication for schizophrenia. It causes weight gain even more than quetiapine, but there's no studies that I am aware focusing on preventing depression. So the answer is, unfortunately, there are none. And of course, to do the studies, first you need to have that formulation as an LAI available. And some of the new antipsychotics that actually seem to be effective not only in treating acute bipolar depression, but also preventing depressions. Some of those medications include lurasidone and cariprazine, and there's another one, lumateperone. They're not available as long-acting antipsychotics. So therefore, obviously, you can't do the studies, unfortunately.
And then so moving forward to our next question, can long-acting antipsychotics be helpful for patients who are not at high risk of stopping medication?
That's a very important question, because we should not only think of non-adherence, think in convenience. I've had patients, I actually, patients who I see, I bring up the option of a long-acting intramuscular early on. It might be convenience, and they might be adherent, but they don't like taking a medication every day. And it might be also that, let's say they are away for the weekend and they chose not to share that they're taking medication with their significant other. So if they're taking the long-acting, that way they don't have to make sure that they remember to take the medication. So convenience is a reason. So it's not just adherence. The other thing that I mentioned is that you guarantee stable blood levels. So lack of adherence is the most important, but not the only one. I would not underestimate convenience. And many of my patients have started just for convenience. Now, how soon should it be start? I would say that discussing the option with the patient, I would say early on. Would I start a long-acting antipsychotic after a first episode of mania? Probably not. And the reason would be because there are patients who have a single episode only. So I would probably strongly consider it after the second episode. Now, with my patients with first episode of mania, and that's one of the areas that I've studied, I do let them know that the medication is available and injectable, because after first episode of mania, if the patient asks me how long should we stay on the medication, and I mentioned before, once there's more than 2 episodes, my answer is always until they're secure. But if it's the first episode, I let my patients know it is possible that is this going to be your only episode. Chances are no more than 10%, but it's possible. And then the obvious next question, when can I stop my medication? I think if you want to be very conservative, 4 years. Conservative, 2 years. But let's say a patient is planning to get pregnant, and she chooses not to be on medication during pregnancy. That's, of course, a decision. I would say, well, let's keep you on medication at least a year, because the risk of relapse is later in a year. So I might have a patient who tells me, well, I'm hoping this is my first episode and I want to stop medication as soon as possible. So I would say, at least stay on the medication for a year. And I would let them know you can do that by taking a long-acting intramuscular and just monthly. And then after a year, we can take it off it and then take it from there. So early on, but definitely after the second episode, but still bring it up even after the first episode. Not that I would recommend it, but I would only on the very special example that I just described.
Thank you. So we have time for one more question today, and that is, considering the half-life of Abilify, when would the LAI dose be out of the system or at the point of sub-therapeutic level?
Well, you mean when if you stop the medication? Yeah. So if you're taking the aripiprazole, and then if the patients, and this is actually an important question, because if you stop the aripiprazole oral, obviously it's out of your system faster. So with the long acting, it can take a week or days, which you could argue the risk of relapsing is lower than if the patient stops oral. So that's a key question, that even if it's stopped, it will be out of the system in days, not in a day like with the oral. Thank you for this last question. And thank you again, folks, for being here today. And again, we do not have a cure. We do not have a treatment that by itself is ideal, but just as one of the options that we have available. Thank you again for being here today.
Yes, thank you everyone for joining. I do want to let you know that this webinar will be uploaded to ibpf.org and our YouTube channel. And if we could not get to your question today, please email info@ibpf.org, and we'll do our best to look into educational resources that can help you with that. And Dr. Tohen, I want to thank you so much for being a member of our IBPF Scientific Advisory Board, and the work you are doing in the field is truly great, and we're honored to have you join us today.
It is my honor, and I have one small request. Can you please send me the link so I can see the presentation?
Yes,
and that way I'll see, well, did I really say that correctly? So next time I do it, it'll be better.
Excellent. Will do. Well, thank you so much, and everyone, have a lovely rest of your day.